Hello, welcome to Integrating Dental Care into Primary Care, a guide for PCPs and dentists. I'm Katie Musser, and we'll be joined by Dr. Andrew Kawasaki and Dr. Nilu Sherpa. All three of us are part of the CMDA Dental Residency Plus program. I graduated from that 3-year commitment in 2019. Dr. Kawasaki is a third year with that program, and Dr. Sherpa is in her first year of residency. I'll tell you a little bit about me. I'm a family of 5. I have a 6, 4, and 2-year-old and have been in Memphis for 8 years and worked for Christ Community while I was participating in CMDA's Dental Residency Plus program. I stayed on board for 5 additional years serving as Plus faculty member, and now am employed by CMDA as the Dental Residency Plus liaison, and I help develop more Plus programs as well as support Plus programs in multiple places. So if you are part of a health center that is curious about intentional and missional dental residency training, feel free to reach out to me. I'd love to talk to you more and see if a dental residency program through CMDA is of interest to your health center program. These are our 4 objectives today that we'll go through. This is going to be pretty fast-paced, so broad strokes. Sadly, I can't go into 4 years of dental school today, but we wanted to just have some common communication that happens between the dentist and the PCP and hopefully develop some common language, maybe give you a little bit of exciting dental terminology and dental education that you may already know, or it may be helpful to have some refreshers on what you might hear or see in your clinics, and specifically towards the oral health of your patients. So let me just start. This will be quickly recognizing oral health diseases. Again, this is all broad strokes. I can't get too in detail due to time, but let me give you some photos here just to give you an idea of what you're looking at. If you are a PCP in the room or listening to this recording and are curious about what can I do really quickly just to get a basic idea if my patients are needing to see their dentist quickly. As you know, it's recommended for patients to get regular checkups with us twice a year, if at all once a year. We know our patient population isn't always going to have the ability to come into the dental clinic twice a year, and so I at least recommend once a year, come in, let's get a checkup. These are pictures of what a healthy mouth are looking at. So you can do this in under 30 seconds. Open, take a look at the teeth. How are the gingiva or the gums looking? You see in that upper right photo some fillings that are silver. Those are amalgam fillings. Those look fine. You don't need to worry if you see silver on people's teeth. It's likely restorations. You want to look at the sides of the tongue. We'll talk some about that in our oral cancer section, but those are some really important areas that some pretty nasty cancers can develop in those areas. So take a quick peek at those areas. Under the tongue is another big one for oral cancer. If you're seeing any kind of notable white lesions or red or ulcerated areas, you need to have that patient see a dentist as soon as possible. We like to look on the inner sides of the cheeks, what we call the buccal mucosa. Obviously, we want to look in the very back of the mouth at tonsils, and of course, under the tongue and the floor of the mouth as well. So caries, pretty obvious, I think, in these pictures. You know, those teeth don't look healthy, okay? That bottom picture is a little less obvious. You might think, well, maybe that's a dark filling or something like that, but in this case, darkness in the grooves of those natural teeth is definitely decay that's likely spreading pretty significantly under the surface there. Clear brown, yellow, and black lesions on the dentition, on the teeth, are concerning, and those would be reason for a dental visit and for some x-rays. Obviously, pain and swelling is another indication that we've got some level of infection or disease going on in the mouth, and we would want to be sure that we're getting evaluated as well for that. Periodontal disease is less obvious sometimes, or less noted if you're just looking with a flashlight or something like that in the mouth. I want to show you in the top there that after picture on the upper right, that's after some periodontal treatment had been done. And so those gums are looking pretty healthy. So that's just a comparison to see when you're seeing kind of a enlarged papilla, that's the gingiva, the gum tissue between the teeth there. If that looks puffy, swollen, bleeding, the stippling, we talk about stippling, which is like little indentations on the gums. This is a good thing. We want to see stippling in healthy gum tissue. When it's inflamed, that means that that stippling has likely been pushed away because of enlargement. So you can see on the bottom pictures, the teeth don't look great. You can see plaque, calculus, just gunk around those teeth. You can see teeth are displaced, likely very wiggly and mobile. That's because the bacteria has gone past the gums and is now actually causing the bone around the teeth to absorb and no longer give the support that is needed around the teeth. So those are some pictures to give you an idea of what you might see in patients, and that is active disease that needs treatment significantly. Patients who have periodontal disease will not ever be in a place where they will gain that bone back, and they must be on a regular maintenance with a dentist for that. They can very easily start to lose teeth. If that periodontal disease becomes aggressive, that bone starts going away quicker and quicker, and those teeth get more and more mobile. And that's the point when we have to start extracting teeth because of pain and lack of function. Oral cancer, there's a ton we could talk about today on this. I've linked that Oral Cancer Foundation there. That's something you certainly can reference if you're curious or have some patients that you're concerned about. But again, we talk about looking down in kind of the buccal mucosa area. What you see in that picture is likely what we call tobacco stomatosis, or an issue where tobacco has been packed in that area and can cause some keratinization of the tissue. So that's something certainly needs to be watched, taken a look at, make sure it's not getting worse. Likely I would refer that as well to a dentist to keep an eye on and make sure that that does not become precancerous or a cancerous lesion in that area. So as I mentioned already, the lateral border of the tongue, the floor of the mouth, and then the buccal mucosa inside that cheek area are really important places that aggressive cancers can occur. So next objective we'd like to touch on today is just educating your patients, some tips, tricks, ideas. You may already be doing this in your clinic. I have had a number of physicians say, I honestly forget this, and it totally makes sense. There's a ton of other things that are going on in your patients' lives, and the oral cavity, head and neck is unlikely going to be at the top of the priority. So I want to basically just empower you to take even just 2 minutes to look in the mouth, ask some simple questions about how your patient's oral hygiene is looking on a day-to-day basis, get an idea for where they may be educationally on oral health. They may not even know that they're supposed to be brushing twice a day. They may not realize that sugar is a major issue and can cause decay in their teeth. There's a number of things that you can simply say in a few seconds to a patient that could significantly help the trajectory of their oral health. And so here are just a few kind of fun things that you already know probably, but these are some things I review with patients. First and foremost, diet. Diet is important. We think about dentists, we think about toothbrushes and flossing and toothpaste, right? Well, actually, where I want to start is diet. I want to say, hey, listen, the sugar that is in so much of our food these days is exactly the fuel that the little sugar bugs in our mouth, the bacteria, the germs in our mouth, love to eat. And when they eat those sugars, they actually develop an acid that actually starts to eat away our teeth. And so if we don't feed sugar to those sugar bugs in the mouth, then we can help our mouth not get as much decay as quickly. And so sugar plus plaque, or that bacteria, plus acid is going to cause a very sad tooth. So not only sugar, but also the bacteria in our mouth. Plaque builds up. We eat food. They like the food we eat, and they like to reproduce and grow. And so we do need to keep up with the bacteria in our mouth. And the way that we do that, the way we clean them, is by brushing, as we all know, by flossing, and importantly, yes, toothpaste. Now, what is super important is people often think toothpaste is kind of the key to oral hygiene. Actually, mechanical mechanisms, the actual effect of scrubbing that plaque off the teeth, scrubbing those sugar bugs off the teeth. And so if the patient doesn't have access to toothpaste, I'm like, okay, that's fine. You need bristles, you need a toothbrush. That's most important. Or if somebody has issues where toothpaste really makes them feel nauseous or gagging them, something like that, that's all right. Let's at least start with a toothbrush and some water and scrub those sugar bugs. The reason we need to floss is that toothbrush does not get between teeth. And the bacteria absolutely gets between teeth. It loves to go down under the gums, and that's when we start having periodontal issues like we looked at earlier. We start to have bacteria that causes infection, inflammation, and bleeding in our gums, and then goes as far, how audacious of the bacteria, to go as far down into the bone and actually start to cause issues where that bone starts to resorb away and move away from the teeth and no longer is a support for our teeth like it needs to be. So it is so, so crucial that we can get people to be flossing, to be able to actually use that mechanical mechanism of the string scrubbing between the teeth gently, but daily. So it's really about the quantity, not as much of the quality. Of course, I want people to be really good flossers, but if they can floss daily with not as good quality of flossing, I'm more happy with that than someone flossing once a month and spending 20 minutes doing it. I would rather them consistently do an okay job of flossing every day than be super thorough once a month, okay? Because those bacteria take about 48 hours for them to start getting more and more happy and more destructive. And so if we can get in there flossing every day, then we're more likely to stop any sort of spread of disease and infection. And then lastly, in the hygiene section, I just think it's really important to explain to people that fluoride is not horrible. It is not the bad guy. Absolutely, too much fluoride can cause issues of fluorosis, and you certainly could go into depth on all of that with a patient. But most importantly, I want them to know that there is a very beautiful and safe range of fluoride that is in toothpaste, which is why toothpaste is important. And what it does is it actually hardens areas of our teeth that have begun to become soft because of the acid from our plaque. And so it basically acts as a medication, or what I call a vitamin against the tooth to make our teeth really, really strong. And so we want patients, if they're using toothpaste, which they should be using toothpaste if at all possible, and we want them to look at the active ingredients and make sure fluoride is in that toothpaste so that they can get the proper vitamins. So, in summary, sugar diet, you need to talk about sugar and acid and how it is a detriment to the teeth if we aren't careful. Secondly, obviously, hygiene from a mechanical mechanism, flossing and toothbrushing. And then thirdly, the fluoride is really, really important as a tooth vitamin. I have printed out coloring sheets that I developed, so the audience who's present for this presentation will receive all of these, but you can certainly email me and I'd be happy to send these your way as well. But I've just put together these little educational sheets that are also coloring pages for kids, but basically just giving some tips and tricks on how we can get better at our oral hygiene. Here's a few linked resources as well. Feel free to check all those out. I have included the coloring sheets and a link there, so hopefully you can actually access that through this PowerPoint. A couple of fun, just debunking common dental myths I wanted to include here. This is more of a fun, engaging the audience situation, and just to talk about things that we often hear and see in our patient population, in our health centers. And you may run across some of these as well. And sometimes it's hard to know, how do I respond to this? So, one of my favorites, Sprite is better for my teeth than Coke. Is that actually true? Why would someone think that? And so the reason is that people know that Coke, because it's darker, can stain the teeth. So, from an aesthetic standpoint, true, Sprite doesn't stain your teeth because it's clear. However, they're both equally as terrible for your teeth, as you can imagine, because they're both sugar and acid, which are the two whammies to cause issues and decay on the teeth. So, what I tell people, especially people who are just adamantly not going to change their soda drinking habits, is one, drink it all in one setting. Don't sip on it all day long. That just causes your saliva to be at an acidic pH all day long, and that's not good either. And so if you can drink it all in one setting, then your saliva will actually bump back to more of a neutral pH and wash over your teeth throughout the day after drinking it. So it's a little better situation. Secondly, even for myself, if I drink a soda, I try to swish some tap water afterward and just swallow it to try to neutralize that saliva even sooner. Bottled water can actually be pretty acidic on the pH scale. So, I mean, if it's all you have, it's better than nothing if you want to swish that around. But I always like to try to find myself a source of fluoridated tap water, which is going to be inundated with fluoride as well as a more neutral pH. Why worry about that tooth if it's just a baby tooth, right? So baby teeth are just as important as adult teeth. They actually hold space for our adult teeth that are coming in. And parents a lot of times think, well, I'm not so worried. And they just kind of let their kids eat a bunch of candy. They don't really help them brush their teeth or floss them. And you start to get some pretty significant issues if that's the case. And so wanting to just make sure we educate our patients that we're developing habits early in our children's lives. And so the more and more we show them how important it is to care for their teeth, the better outcome their adult teeth are going to have. And also, if baby teeth have to be extracted or taken out sooner than they were supposed to be, then you have a lot of issues where adult teeth coming in can be really crowded, and you have more issues where you're going to need orthodontics and braces. Do I need to use a harder toothbrush? We have a lot of patients who are trying to be so thorough and end up using hard toothbrushes, and we know it right off the bat because there are certain abrasions on their teeth that are classic abrasions that happen when your toothbrush is too hard. So please inform your patients soft toothbrushes are the key. Again, it's not about quality. I know that sounds funny. It's about quantity. I want my patients brushing at least twice a day, morning and night. Don't scrub super, super hard. You're actually going to cause issues. Just gentle, do that for 2 minutes, chill out, do it tonight before bed, and do that every day of your life, and you should be doing pretty good. All right, so our last objective here is to provide a common language between PCPs and dentists. And I'm going to let our two current plus participants, Dr. Kawasaki and Dr. Sherpa, give some insight on updated research on a few big topics that we run into in the dental clinic. Often we run into needing to consult a PCP of our patients to say, hey, what do you think about doing certain dental treatment due to these medical conditions and issues? So I'm going to let them give an update on that and develop a common language between dentists and PCPs.
Okay, I will now talk to you about antithrombotic agents and dental treatment. I know that I have in the past sent medical consults to primary care providers asking if an antithrombotic needs to be kind of withheld before I complete an extraction or something like that. And sometimes I even walk into a room and the assistant says, we can't do anything because they're on a blood thinner and we need to talk to their physician. In my research, I've seen that that's not always the case, but that is a common school of thought, and that is why this topic is important to bring up to all of you who probably are way more well-versed in these medications than I am. So now we will kind of talk through why this matters. So as you know, something like warfarin or clopidogrel, any type of thing used to prevent blood clotting, is typically prescribed to prevent thromboembolism, stroke, or myocardial infarction. Those are serious things. Reasons that a dentist or someone might want to stop those or modify that treatment is for concern during surgery about prolonged bleeding, bruising, and just uncertainty of what could happen. These are kind of the things on that teeter-totter that could lead to help make our decision. So I know a lot of dentists are really concerned about that bleeding and bruising, but I do think we need to be more concerned about those larger risks that could ultimately lead to the death of a patient. And so when considering whether or not, or what to do with a patient on antithrombotics, it's important to look at the risk of bleeding with the dental treatment and look at the thromboembolism risk. So here, a lot of words on the screen. I know, just want you to look at the risk of bleedings. So most simple extractions of 1 to 3 teeth are really low bleeding risk. Something like an incision of drainage, so there's a swelling there. If we can cut into that, drain some of the pus, that's also low bleeding risk with that. Moderate bleeding, something like a deep cleaning or a surgical extraction. And then high bleeding risk in the dental field would be kind of things that more oral surgeons or periodontists would typically do, not really general dentists, although that may happen occasionally. So important to have this somewhere. And this all comes from this article, Perioperative Management of Dental Surgery Patients Chronically Taking Antithrombotic Medications. And that is one of the articles that I will be referencing a lot. So like I said, the second arm that we need to look at is thromboembolism risk. So here it lists the different things that put a patient at high risk for a thromboembolism, such as a prosthetic heart valves, a history of thromboembolism while on antithrombotic therapy. Some important things to note is that in these patients, there is a high risk for complications after stopping antithrombotics. And there are certain cases, I should say, when if there is a high bleeding risk, then there might be worth considering interrupting the treatment, or if the patient's on warfarin, then bridging that warfarin. So stopping the warfarin, taking a low molecular weight heparin in order to decrease the bleeding risk while still having some anticoagulation therapy going on. Then everything else that wasn't on that slide really is low thromboembolism risk. So for this low bleeding risk and a low thromboembolism risk, no need to worry about changing antithrombotic therapy. Maybe with the exception of warfarin, which I will talk about later. For moderate risk bleeding procedures, you may consider interrupting warfarin or the direct POAC medications. And bridging for warfarin typically isn't recommended for these low thromboembolism risks. Here is one example of a table, just how to think through these. And this is specifically for patients receiving double anticoagulation therapy. And you probably know way more about what this means than I do. I can do more research and remember. But the same article from before has this and many other tables that will be available in the PowerPoint for your reference. So in specific, when talking about warfarin, you need to keep in mind that if you discontinue warfarin, there often is a rebound hypercoagulability. And so just kind of interrupting that, not doing anything else, really is not recommended. And in general, it's best practice to just recommend that the dentist get an INR the same day as the extraction. And if that is 3.5 or less, then they're good to do a simple extraction. If the patient does have diabetes or liver disease or chronic renal failure, then we want that INR to be 2.8 or less. And especially with this, we do want to tell that dentist to have post follow-up. A good thing that I always say to patients that I've heard and seen in the research is there's really bleeding is expected after something like extraction for 24 hours. If the patient closes their mouth and feel the mouth filling up with blood, then that's reason to be concerned, reason to either come back and see the dentist, or if the dentist isn't available, then go to the ER for concern about bleeding. But like I said, if you're doing a good job thinking about what your risks are, then we can manage these patients pretty well, often without interruption of the antithrombotics. And here are some other resources. There is a lot out there. I wish I could share more and talk more, but there is not time. The next topic I want to touch on is pregnancy and dental treatment. I've had many patients come to me after being pregnant and say they were in pain their whole pregnancy from a tooth, and they just didn't come in because of fear of complications. And I've had many other patients who don't think that they can get anything done because they are pregnant, or I've had other dentists or hygienists who are hesitant to do anything on people who are pregnant. So I just want to touch on this. There are clear reasons for concern, and there are many things that can cause spontaneous abortion, teratogenesis, or fetal hypoxia. So it is good and right to be concerned about what is going on in a pregnant patient, and also concerned for the patient's well-being and the expectant mother's well-being. And some things to just remind us that happen are increased appetite and cravings that can lead to an often increase in a high fermentable carbohydrate diet, which, as Dr. Musser talked about, does increase the risk of cavities or dental caries. And there can be nausea and vomiting, which can increase the risk of enamel erosion, and immune suppression, increasing the risk of gum disease and other infections. So all of what we see with the expectant mother makes us see that it is important to be taking care of the dental health and oral condition during pregnancy. In terms of what is safe and what is not, in general, really most things that we do in dentistry are completely safe and often necessary to complete during pregnancy. There should be a focus more on controlling active disease, dental caries, periodontitis or gum disease, and eliminating potential problems for later in pregnancy and the immediate postpartum period where it is hard to get to see a dentist. Here I have outlined just some major things that can happen in the different trimesters, really because of the risk of the damage to the fetus or that embryo. Do you want to avoid elective treatment and really focus on urgent care during that first trimester? But cleanings and are totally safe and really important to be doing good plaque control and instructing patients about good oral hygiene, something that all of us can do better at. Sure. Here's a picture of my wife when she was pregnant with my son who's here. Some things that I've seen was that increase in carbohydrate diet, but also you can see the large size of that uterus, and you can think with a dental treatment, we often have patients sitting back in a chair for 15 minutes up to an hour. If we're doing something more intense, maybe a little longer than that, which is just important to keep in mind that uterus will be pressing down on the vena cava and can cause supine hypertensive syndrome. So helpful to remind dentists you talk to about treating pregnant patients, and even to remind your patients that if they start to feel bradycardia, sweating, nausea, or weakness, or like air hunger when laying back, have them turn over onto their left side. And that will increase that venous return and bring them back to normal. So here are some of the common oral complications with pregnancy. So I talked about the immune suppression being a symptom of pregnancy, and that can lead to an increase in pregnancy gingivitis, or what we call, and just the increase in the bacteria that really irritates the gums. So very important to just emphasize oral hygiene. If you see a patient who's pregnant, recommend asking if they've seen a dentist and recommending that they find one if they haven't. And then here's a picture of a pyogenic granuloma. And this is kind of a response to local irritation and an exaggerated immune response. Is benign, but it does look pretty nasty. Most of the time after pregnancy, that will go away. A large one like this may need to be removed, often with a laser, to help decrease the risk of bleeding. Dental caries could be seen as a complication. It's not because the soft teeth or because of the baby taking away the calcium from the teeth. The calcium in the teeth is very stable in the very hard crystalline form, so it's not available for the body to kind of reclaim. It really is more related to all that Dr. Musser talked about, fermentable carbohydrates in the mouth, pH being off, and all of that. There can be some tooth mobility related to that pregnancy gingivitis. Most of the time after giving birth, that does go away. And like I talked about with the nausea and vomiting, dental erosion can happen from that. What we recommend for patients is not to brush their teeth right away. That can kind of just spread the acid around and kind of wear away at what is being attacked by the acid. Rather, it's best to kind of rinse out the mouth with water or water with a little baking soda, and that can help neutralize a lot of that acid. With that, the main takeaways that I do want us to have is dental treatment really is safe with pregnant patient, or for a pregnant patient, and it is really beneficial to use that time when patients typically are motivated to take care of their health to include trying to get them to take care of their oral health. And here are some resources for that. One other thing that I didn't mention is just the use of lead aprons. Taking x-rays during pregnancy is totally safe with our modern technology and digital x-rays. In fact, the ADA recently did come out with new recommendations saying that a lead apron isn't necessary. But most research that you'll find will recommend using a lead apron with a thyroid collar during pregnancy. So I think it really goes on right now what the patient is comfortable with. And here are resources, and that is it. Thank you for your attention.